Good morning, everyone. Welcome to Mass General Brigham Global Health Grand Rounds. It's my real pleasure to introduce two absolutely wonderful colleagues and speakers this morning who are going to speak to us about maternal health and improving the quality of maternal health in resource-limited settings, the power and pitfalls of digital innovation. We're going to have speaking Dr. Adeline Boatin, who's an assistant professor in obstetrics, gynecology, and reproductive biology at Harvard Medical School. She's an attending at Mass General Hospital. She's a researcher, clinician, and educator. Through her research, she aims to reduce global reproductive health inequities and has a focus on using digital technology to improve surgical care, ranging from decision-making for surgery to post-operative recovery. Her current research portfolio explores wireless monitoring technology to overcome human resource limitations in post-op care, and she also leads a multi-site and multi-country study examining cesarean delivery use in sub-Saharan Africa. We also have with us Dr. Bethany Hedt-Gauthier. Dr. Hedt-Gauthier is an associate professor of global health and social medicine at Harvard Medical School. She's a biostatistician specializing in health systems and implementation science research in sub-Saharan Africa. She leads a portfolio of research on improving care access and outcomes for women delivering via cesarean section in rural Rwanda. Dr. Hedt-Gauthier is committed to improving partnerships in global health research by innovating within her own practice and by leading research and advocacy on the issues of power dynamics and inequitable research collaborations. Delighted to have you both, and I'm going to hand over to Dr. Boatin to take us away. Thank you.
Great. Thank you, Louise. Just give me a second to get the screen share going correctly. Not at the beginning. All right, so you should see the slides, hopefully in the right view.
Yes, we do.
Okay, thank you so much for the introduction. So it's a pleasure to be here today to share with you some of the work that we're doing, and even more of a pleasure to share the stage with Bethany this morning. We wanted to start off with just giving a little bit of a positionality statement. Louise kindly gave us a really nice introduction, but I think I have started to incorporate this into presentations I give, because I do think that especially when we're doing research, everything that we do is framed by the perspective with which you're coming. And some things may be obvious and other things may not be obvious. So I'll start with my positionality statement. I am a Black African woman. I was born in Zambia to Ghanaian parents, and I'm a citizen of Ghana. I've had the privilege of living in 4 different countries, in Zambia, Ghana, the United Kingdom, and the US. And I received a secondary school education at private institutions in high-income countries and my medical school and residency training in the United States. I'm currently employed in a well-resourced facility in a high-income country where my clinical work is based. And although most of my research is based in Ghana and Uganda, and though I spent significant time in both countries, I think it's important to note that I'm not an active practicing clinician in either country. So that's just a little bit about my background, and I'll just hand over to Bethany to share a bit about her.
Thanks, Adeline. And excuse me, I echo the sentiment of happy to be here and really happy to be here with Adeline. Just a little bit of my background. I'm a white American woman, grew up in North Carolina. I trained in mathematics and statistics at various universities in the US. I've spent half of my adult life living in various countries in sub-Saharan Africa, primarily Malawi, Namibia, and Rwanda. And while most of my research now is in Rwanda, I am based in the US at a high resource institution. Over to you, Adeline.
Great. So I thought we would start off our presentation by just going over a few of the basis statistics. And, I think some of us might know these numbers, but it's always a good to pause and reflect and remember them. And actually, this is quite timely because about every 3 years, the WHO, UNICEF, World Bank release statistics on maternal mortality. And the most recent statistics were actually just released a couple weeks ago. So you have sort of the most up-to-date numbers here. And what we can see with the most up-to-date numbers is that global maternal health remains a global public health priority. So in 2020, which is going to be the most recent numbers that we have, an estimated 287,000 women died in childbirth. And that translates to about 800 per day, or 1 death every 2 minutes. Now, this is a third lower than in 2000, where there were 446,000 maternal deaths. So we have made some progress over the last 20 years. I think it's important to note that the statistics that were released in the most recent report show that the progress has been uneven, and probably most concerning, that the progress is stagnating. So most of the reduction in the maternal mortality that we've seen between 2000 and 2020 was in the first 15 years of the Millennium Development Goals era. So the average reduction there was about 2.7 per year. And in the last 5 years, we really have stagnated and almost actually have gone a little bit backwards. So I think this is important to note, given that we are currently, 7 years away from 2030 with the Sustainable Development goals. I think it is important to know the numbers, but I also think it's important to take a step back and think about what each number means. And I always put this slide up here with a picture of Sarah Bira, who was a midwife that worked for a few of us here at MGH and colleagues in the Imbarra University of Science and Technology. And she worked on a study looking at postpartum infection and joined us when she was just 3 months pregnant, and unfortunately died in childbirth at the Imbarra University there. And I think her story just reminds us that each death is a life story. And just as I have her up there, just to honor her, I wanted to read some words from Mahmoud Fatalo, who is the former president of the Federation for International Gynecologists and Obstetricians. And he says that maternal mortality is not words, it's not numbers, it's women who have names. It's about human faces seen in the throes of agony, distress, and despair, faces that live forever in our memory and continue to haunt our dreams. This is not simply because they are young women in the prime of their lives who die at the time of expectation and joy, leaving behind children and families in bad need of care. It's not simply because a maternal death is one of the most terrible ways to die. It is difficult to think of a more terrible way to die than a maternal death, as it occurs in parts of the developing world today. The most distressing thing to us is that it is, in almost all cases, a tragedy that could have been avoided and should have not have been allowed to happen. So a few points to also emphasize the numbers that we've talked about is that although these are huge momentous occasions in people's lives, unfortunately, it's actually quite difficult to measure. Likely, the numbers that we're seeing are underestimated. The most robust sources for maternal mortality come from civil registration and vital statistics, which are most often underdeveloped in many of the places where the rates are the highest. And so a lot of these numbers are based on household surveys or service statistics where hospitals report them to the national services. And as you can imagine, those are likely very much underreported. So when you take these numbers, please take them with a grain of salt and think that they're likely much higher. There are also quite significant inequities in maternal health and mortality. And it really reflects on where you happen to be born happens to determine your risk. And so here I have a few numbers of the risk of a 15-year-old dying in childbirth during her life. The lowest risk is actually in Belarus, where it's 1 in 65,000. And the highest risk is in Chad, where it's 1 in 15. And you can show that tremendous disparity there. And just putting this on sort of the map, Sub-Saharan Africa accounts for most of the world's maternal deaths. So although Sub-Saharan Africa has 16% of the world's population, it accounts for 70% of the world's maternal deaths. And actually, one country alone, Nigeria, accounts for actually 28% of maternal deaths. And also Sub-Saharan Africa accounts for 31% of the world's fetal and neonatal deaths. As we think about maternal mortality and maternal deaths, I also think it's important to remember that death is just the tip of the iceberg. And so in some of the work that we do, it's really, we're trying to avert death, but we're also trying to bring into to the clinics a place where you can have actually well-being around childbirth. So beyond the hundreds of thousands of maternal death, there are millions of other unaccounted for complications often. These are things such as hemorrhage, uterine rupture, hysterectomy at the time of delivery, fistula that might occur from obstructed labor, and then untold numbers of mental trauma and depression. So it's clear that we need a change as we want to achieve the Sustainable Development Goals. And just to remind us all, the goal for maternal health is goal number 3.1, which is by 2030 to reduce the global maternal ratio to less than 70, with no single country having a maternal mortality ratio of greater than 140. And just to reflect back to the first slide I showed, the current maternal mortality rate on average is 210. So we're far off from that. And we definitely need a change, a significant acceleration in progress if we to achieve this SDG in the next 7 years. So we're focusing on quality, and this is something that has been on the global agenda over the last several years. There have been numerous publications that have focused on this as regards to maternal health. And previously, a lot of the emphasis had really been placed on trying to get women to deliver in facilities with the thought that if you can get them into facilities, then they should have the resources and the skilled attendants to help hopefully reduce some maternal mortality. And while increase is in facility-based birth have made a difference, it hasn't made quite enough of the difference. And so this reflects a lot of the work on quality that we see in many other spheres of health. The Lancet Global Health published this series on the impact of lack of quality of health on health systems. And this is emphasized by this slide here, where you can see this graph here. And basically what this shows are countries that all have achieved at least a 70% rate of institutional delivery. And you can see that even within each income group, there's still a significant variation in the maternal deaths that happen in these countries. And actually, when you look at it all together, about over half of maternal deaths in low and middle income countries happen as a result of poor quality of care and not necessarily lack of access or non-utilization. And I think this bears out, just to take a step back, because we are in the US, to think about maternal mortality in the US, the importance of quality bears out here. And I just wanted to put a few of the statistics around maternal mortality in the US up here. So the US actually has the highest rate of maternal mortality amongst its I'd say peer group of OECD countries. And this is very different depending on where you are in the US and which state you live in matters, and also who you are in the US. And we find that rates of maternal mortality are 4 times as high for Black women compared to white women and Hispanic women. And this is true regardless of socioeconomic status. So actually, if you take out even women who are highly educated and with high income, they still have significantly higher rates of death. And there are many reasons that go into this, but it really also translates into the quality of care that they receive when they go into institutions. So when we think about quality, what do we mean by this? And there are a couple of ways that I approach this. So high quality health systems can refer to systems that constantly deliver services that improve or maintain health, are trusted by people, and could adapt to changing needs and health shocks. And I think of it really as the right care that's tailored to the local burden of illness, received by the right woman at the right time and in a respectful manner. When you think of these quotes, it's helpful to break them down into actually operationalization. And so a lot of the work that I do really thinks about these 6 elements of quality as framed by the Institute of Medicine: care that should be equitable, timely, effective, safe, efficient, and patient-centered. And we can think about how this plays out in terms of the structure where people receive care, the processes of how care is given, and then the outcomes of that care. So thinking about digital innovation, where this comes in, I think it provides us a tremendous opportunity to deliver services that we previously have not been able to. And the facts are that there are simply not enough resources to go around, and those resources are unlikely to change, particularly in sub-Saharan Africa, as I mentioned, where there's the greatest burden of maternal health. The number of health workers there is vastly unsuited to meet the needs. And so we have to think about how can we work smarter and not just harder. And we've seen how digital innovation over the last 10, 15, 20 years has really made leaps and bounds in how people living in even the most rural areas can receive financial access or even access to media and the news. And so what we're thinking, and a lot of people other than us are also thinking, is how can we leverage this power of digital innovation to improve the quality of health services? So I'm now going to pause and hand over to Bethany, who's going to talk us through one of our first case studies, and then I'll come back and talk about our second one.
Thanks, Adeline. So I'm going to be talking about some of our work in Rwanda, where we're using this digital innovation that Adeline described to address some of the gaps in post-operative care for women who deliver via cesarean. Next slide, please. And I'm going to represent about 8 years of research in less than 10 minutes. I have here our current study team, and it's full of both collaborators and field implementers and students and trainees who really have shaped this work, but know that this is just a snapshot of the numerous individuals who've been supporting this work over the last 8 years. What we're working towards is home-based care for women after cesarean delivery in rural Rwanda, led by community health workers. And I'm going to provide a little bit of specific context for Rwanda about why we think this is the right approach at this time. As background information, globally, cesarean rates are linked to lower morbidity and mortality. However, because there are increasing numbers of cesarean deliveries, there is also an increased number of post-operative complications that are being observed. In sub-Saharan Africa, around 8 to 48% of women who deliver via cesarean delivery go on to develop a surgical site infection. And generally, these infections develop after discharge from the hospital. Specifically in Rwanda, around 15% of women are delivering via C-section, although this is lower for poorer women and for women who are located in more remote settings. And also in Rwanda, there's already a cadre of community health workers who support women during the prenatal period and who support women who deliver vaginally after delivery. But because of the complexity of cesarean delivery and cesarean recovery, these community health workers don't currently support women who deliver via C-section. And those women are required to go back to the hospitals for post-operative care. Next slide. So why home-based follow-up? Around 11% of C-sections in the areas that we work those women go on to develop surgical site infections. We have numerous studies that have shown that the long distances that women have to travel to seek out care are linked to poor maternal and neonatal outcomes. C-sections follow-up has been reported by women to be both physically and financially burdensome for them. And then finally, we found that C-sections itself, so the cost of cesarean delivery up to the time of discharge, is financially catastrophic for about 1 in 4 women. However, when we take into account the cost of the post-operative follow-up, the cost to go back to the health facility to receive that cesarean-specific care, this increases to 3 out of 4 women facing financial catastrophe due to that follow-up care. Next slide, please. So linking this back to Adeline's comments around quality of care, we really do think the context of providing home-based care itself addresses the issues around having equitable care, timely care, efficient, and patient-centered care. However, there are some concerns about issues around whether or not this is safe to have women monitored by community health workers for post-operative complications, and we primarily focus on surgical site infections, and whether or not this home-based monitoring is effective in terms of ensuring that women are linked back to care in a timely manner if complications do arise. So we propose, if you can go back, sorry, we propose a digital solution to try and address these 2 aspects of the quality of care framework. And it's a particularly exciting time to be doing this in Rwanda because Rwanda now has the first Africa-made smartphones. So smartphones are becoming more readily available. And there's a commitment by the Ministry of Health to equip all community health workers with smartphones within the next few years. And so there is a platform to deploy some of these interventions if we can develop safe and effective interventions to be used on these platforms. Thanks, Adeline. Next slide. So we've been working at this for several years, and we had 2 previous studies. The first study, we developed a simple clinical screening protocol where if a woman responded yes to any of the clinical questions, she would be referred back for being at high risk for surgical site infections. In the second attempt, we had a community health worker capture an image of the surgical wound and send that to a general practitioner for real-time diagnosis. And in both of these studies, we demonstrated that it was feasible. It was possible for community health workers to gain access to women in their homes. Women permitted them to do this type of follow-up, allowed them to take the photos. For the second study, we showed that it was feasible to get the images to GPs in real time and to receive back a GP diagnosis based on the image in real time. And we also have done qualitative work that's demonstrated that it's acceptable both to the community health workers and to the women to receive care in this way. However, for both of these studies, we struggled because the accuracy of the surgical site infection diagnostics was too low to really safely deploy this in these home-based settings. Next slide, please. So we're now working on attempt number 3. Again, we think that this is the right aspect of care for women after cesarean delivery. But before we can deploy this, there's 2 things that we need to work on. First is we need a better and more accurate surgical site infection diagnostic tool. And the second is in conversations with the Ministry of Health officials, they've said it's great that you're targeting surgical site infection. That is a high risk complication post-cesarean delivery. However, we would never only assess for surgical site infection. There's other complexities after cesarean delivery that we will need to make sure that we're monitoring and ensuring that women are safely recovering at home. So these are the 2 things that we're working on right now. Next slide. So the first is the surgical site infection diagnostic tool. Over the first 2 studies, we captured sets of images that are accompanied by GP surgical site infection diagnostics. And we've been using these sets of images to develop machine learning-based algorithms to predict surgical site infections based on the wound images. I have summaries of 2 of these different approaches. The first uses cameras from the smartphone itself and just captures a wound image. You can see on the leftmost images, we have developed an app that helps capture the image in a standardized, high-quality way. And then we also use a target that both frames the wound, but allows through those color blocks to do color calibration for different lighting. So with this algorithm, using these photographs from the phone, we're able to develop an algorithm that has 81% sensitivity and 65% specificity. In a second study, we actually add a thermal camera add-on to the mobile device, where instead of capturing photographs, we capture heat profiles of the wound. And with these heat profile images, we're able to develop an algorithm that maintains about the same level of sensitivity, but has a much higher level of specificity. Next slide, please. The second piece, as I mentioned, is the more comprehensive assessments. And so we've been working with a team of expert advisors to develop consensus guidelines on what we should care about or what we should be monitoring for after a woman is discharged from the hospital. We've been using these guidelines to develop what I call our low-tech tools, which I think are also innovative, different pamphlets and flyers that we can use to educate women at the time of discharge about the things that they should be monitoring for themselves in terms of recovery. And then we've been taking this information and putting it onto the mobile app such that when community health workers go to the home, not only are they doing the image capture for surgical site infection diagnosis, but they're also walking through these series of screening questions to ensure that the woman is indeed recovering safely in other aspects of her recovery. Next slide. So just briefly, some next steps for this work. We're currently programming that mHealth Community Health Worker app and entering in actually next week some usability and acceptability studies with community health workers. And then in the fall, we'll be doing a prospective cohort to validate the safety of this tool, and then followed up with a randomized trial to evaluate the impact on time to diagnosis. I'm also doing some work with Adeline and other colleagues to evaluate the generalizability of this diagnostic algorithm with the goals of testing this algorithm in Ghana and Mexico to see how it performs in other populations. So I'm going to hand it back over to Adeline to present a second case study for us.
Thank you so much. So we're going to go back from out of the community back into the hospital and think about how we can use digital innovation there to improve the quality of care that women receive within the hospital and similarly around the time of C-section. So as Bethany mentioned, cesarean section rates are increasing, and we do know that we need some increases in C-section rate to help reduce maternal mortality, although up to a certain point, and that's a whole other talk that we can get into about increasing and high C-section rates. In 2018, there were 2 studies that were published that looked at the complication rates of C-sections in sub-Saharan Africa, in particular one study, and in low and middle income countries in more generally, broadly, and that was a systematic review. And what both those studies showed is that the maternal mortality rate after C-section was about 40 to 100 times higher in sub-Saharan Africa and other low and middle income countries compared to in high income countries. And stillbirth and perinatal rates were also significantly higher. And so the maternal mortality rate after C-section was close to 0.5 to 1%, which is very high. Complication rate was close to 1 in 5, so about 17% of women experienced a complication. And when thinking about what were some of the drivers for these high rates of complication, and specifically complications that actually resulted in mortality, one of the things that came up was in this failure to rescue post-operatively. And so we know that anytime that someone undergoes surgery, there's a risk of a complication. And one of the challenges is to identify that complication in a timely fashion so that one can intervene and prevent further complication and certainly prevent a death as a result. And so when you think about this critical failures model, you can think about failure in providing timely access to care, which can actually also increase complications, what happens during the actual surgery itself, but also importantly, what happens post-operatively. And we looked a little bit about how we were doing in terms of identifying women who might have a post-operative complication. And this is really done by looking at vital signs and evaluating patients. And so in Imbarara, we did a retrospective review, and this was back in 2013, and looked at documentation on vital sign monitoring at admission, intrapartum, and postpartum. And here you can see some of the results from what we saw happening postpartum. And this is both actually true for women who delivered by cesarean and by vaginal delivery, but there were very low rates of monitoring after childbirth. And those first 2 hours after delivery are very high risk times. And to put this into context, normative international standards so that women would have vital signs measured at least every 15 minutes for those first 2 hours, because that's how you can pick up a hemorrhage that's evolving or worsening pregnancy-induced hypertension. And so here, just focusing on the 119 women who had a cesarean delivery, if you look at that first 4 hours of postpartum, no woman received high-quality monitoring. And what we meant by that is having at least 1 heart rate, blood pressure, and temperature collected in those first 4 hours. And even if you look at the individual levels, it was really less. The highest was 4%, which was blood pressure being measured in that first 4 hours. And even if we extended that to the first 24 hours after delivery, only about 1/3 of women were having any vital signs measured individually, and 4% having high quality monitoring. So there's a lot that goes into why this deficit might be happening. The external factors might deal with the education, knowledge around vital sign monitoring, the organizational culture, the environmental design, the provider to patient ratio, as I mentioned, is a significant challenge, and also the equipment availability. This might feed the attitudes toward the behavior, the normative beliefs around this, and then your perceived ability to actually do vital signs collections. That drives the intention and then what actually happens. And so one of the hypotheses or theories that we wanted to try is if we could eliminate a lot of those barriers to actually having vital signs monitored, particularly where it comes to the provider to patient ratio, by using smart technology to do this. And I'm sure most people here in the audience, a lot of people have some sort of wearable that's monitoring them right now. And so we wanted to look at technology to be able to achieve similar levels of monitoring in the inpatient setting. We started off with a pilot using both a device called the Zephyr device, which you can see there, that's placed on the sternum. And that was a device that measured heart rate, temperature, respiratory rate. And we tried this in 50 healthy women in early labor. We had 10 clinicians try to use it, monitored them for 30 minutes, and just tested to see if we could do this in a low resource setting where you don't necessarily have robust wireless networks and power might go off and on. And we found that we were able to capture 80% of continuous vital signs, over 90% of the women found it comfortable, and 80% of and 100% of the clinicians would recommend this to others. So we took this pilot data and used this to inform a larger study to see if we could use wireless physiologic monitoring to help reduce maternal mortality and morbidity by improving quality of care. So this study was formed the basis for my K23 work funded by the NIH, and that we did this as a hybrid effectiveness implementation study. So really we were trying to see both the effectiveness, could we actually reduce morbidity and mortality, but also how did it do in terms of implementing this into the workflow. And so this was quasi-experimental. We ultimately decided not to randomize women to vital sign monitoring or not, because we all know that that's, well, there are a lot of ethical challenges around doing randomization at the individual level. And so we ultimately settled on a study design where we did an interrupted time series where we would have repeated on and off periods. In this particular study, the population were women who were delivered by emergency cesarean delivery during the study period. And we also included the clinicians who were responsible for their postpartum management and care. So what the intervention was, in this case, we used a device that was provided by Current Health. And so this is a company that started in Edinburgh and has since actually grown and is providing care internationally. I think the COVID pandemic and the need for remote monitoring has really expanded their services. And you can see in the picture over here, there's this, one of our participants was wearing the monitor on her arm. It's basically about the size of a phone or a pack of cards, and it's worn with a wristband, and has the ability to measure heart rate, temperature, oxygen saturation, respiratory rate, movement, and position. And then we had a separate device that measured blood pressure, which was done manually, but the data from that would still feed into the overall application. And so for these vital signs, once collected by the device, would go to the cloud. And from the cloud, you could visualize this on an app, on a phone, or a dashboard on a computer. The other advantage of using this system is that we were able to put in an algorithm such that if women developed an abnormality in one of the vital signs, that would trigger an alert to a clinician carrying what we called an emergency responder phone, so that they would be aware that a patient was having this abnormality. We didn't dictate what they did with that alert, what type of interventions happened, but we were just providing the information as part of this study. And so our primary outcome for the study was severe maternal outcome, and we based this on WHO numerous criteria. And so there's a large list of potential adverse outcomes. And our baseline assumptions was that the baseline rate of severe maternal outcome was 13%, and that was based on a study that was performed in Mulago, which was a similar level tertiary care hospital in Uganda. We thought there'd be about 8 to 10 C-sections a day. We'd have about 85% recruitment, and that we would be able to detect a 5% difference in severe maternal outcome. So as I mentioned, we had the repeated on and off periods. So we would have 2 weeks where everybody who met study criteria would wear the device, and then 2 weeks where we would have the on and off, the no intervention. We didn't quite have a seamless repeated on-off series because there were numerous interruptions to the study due to the COVID pandemic. Alongside the clinical outcomes, we were also, as I mentioned, doing a hybrid study. So we looked at some of the implementation pieces of this, how much we were able to reach the target population, the percent of women who were able to get the vital signs that we needed, the percent of eligible clinicians, and how well we were able to stick to the study protocol. So the study is finished enrolling. We're still doing some data analysis, so take everything here with a grain of salt. But over about 2 years of enrollment, we assessed nearly 4,000 women, and just about 1,500 women were consented for monitoring, and about 1,600 women were allocated to the control. On average, these were young women, mostly married. About a quarter of them were referred in for their C-section from another facility, about 10% rate of preterm birth, and mostly had had a prior delivery, and actually about almost half, 40% in both groups, had a prior C-section, and more than half would arrive in labor. So in terms of the intervention, as I mentioned, we recruited and allocated to this about 1,500 women. Of those who were recruited, at least 96% had at least one observation from the actual device, and over 75% of women had over 20 hours of continuous monitoring, and less than 5% had a 4-hour gap in monitoring. So this speaks to the feasibility of being able to do this in a low resource setting. In terms of the clinician adoption, so this was mostly midwives who were carrying our emergency responder phone. And on average, they received about 1 to 2 alerts during their shift. And most of them were able to evaluate the patient after getting alerts. So about 90% of the patients where they got an alert were assessed, and then about half of them would have some sort of intervention done. And so that might be as simple as, treating pain, or sometimes providing blankets to help keep them warm, and sometimes something more extensive in terms of medications or managing bleeding. In general, the clinicians found this quite acceptable. So virtually 100% said that this improved their care. Just about 70% thought the number of alarms that they received were just right. And again, just about 100% would recommend this for routine clinical care. Mostly they found it useful, and particularly in being able to view the vital signs. And we also thought it was important to think about how stressful this was, because there isn't necessarily here a culture of holding a pager. And for those of us who hold pagers, you can imagine sometimes that's stressful, and I didn't want to be the person to introduce this without hearing from them about whether this was actually adding to their burden. But most of all, they found this not at all stressful. We did some qualitative work to understand their experiences, and I just wanted to share 2 quotes from a midwife. So in one, she said, "I appreciated it because I was able to know my patient's condition when I'm not with them face to face. You are somewhere and you need to know the blood pressure of the patient at a specific time, then you can read it." Another midwife said this particular patient was shivering alone on the bed. The wheelers had picked her from theater and put her in a certain bed in postnatal, but that time we had another emergency in the labor suite. I received an alert on my phone saying skin temperature very, very low. So I reached out to the patient and found her shivering, no bed sheets. We covered her and managed to get a warm drink for the patient, and she became fine. The women themselves also found the devices very acceptable. So, one of the things about childbirth is this is generally a healthy population that's going to be back on their feet, hopefully very quickly. And so we wanted to make sure that having a device that they had to wear continuously for 24 hours would be comfortable for them. And most of them found it comfortable or very comfortable, that it would be compatible with breastfeeding. And again, most of them found that to be true. They had confidence in the monitor, in fact, and I didn't have some of our qualitative statements here, but maybe too much confidence in the monitor, thinking that it did things that it didn't actually do. But mostly they would use the monitor again and recommend it to a family member. Now, when it came to our primary clinical outcome, we actually found a much lower rate than we anticipated based on that study that I mentioned that came from Lago. So the overall rate for a severe maternal outcome was 2.5%. You can see here that there was no difference between the control arm and our intervention arm. Even when we looked at high-risk women, and those are defined as women who were living with HIV and women with obstetric complications such as preeclampsia or antepartum hemorrhage, the rates of severe maternal outcome were slightly higher in that population, but again, there was no difference in the clinical primary outcome. So I had to sneak one African proverb in here, and I think one of the things that I learned from this study, and a lot of the studies that here, it's like there's no panacea. There's always lessons that you learn and you do better next time. And that speaks to Bethany's work, where she showed the several attempts. And so, yeah, and even in this case, there was no direct route to the top of the palm tree, and simply putting the monitor on is not enough. There's more work to do. So there are a few lessons that we learned from this. First, there are some caveats. I think, as I mentioned, this was a repeated on-off study design, and that in of itself has its challenges and limitations, but then that was also hampered by the COVID, and there was some spillover. We did find that this was feasible and it was desirable in a resource limitation, and so that's very important and had important benefits both for the clinicians and the patients beyond the hard clinical outcomes, but it is not quite ready for prime time. So our next steps are figuring how to do this better, because I do think that this type of technology has a role in helping extend the human resources in patient care. So we need to figure out when it should be used and who it should be used on. Who should we risk stratify, because perhaps we can't have every woman use this, and who are those higher risk women that we should put it on for? How long should we monitor? Perhaps we can identify that if we monitor certain women in the first 4 hours and their vital signs at a continuous level are completely normal, perhaps they don't have to wear it for the continued next 24 hours. And maybe in other women, they should wear it for beyond the 24 hours. So some of these questions on how we can figure out how to do this better, we're going to put together towards an R1 application, looking at doing this in C-sections, but also in other types of postoperative monitoring. So I'll pause there and hand back to Bethany, who will talk about some of our challenges with digital care.
Thanks, Adeline. So hopefully you're feeling very inspired that these issues are important, and hopefully you're feeling convinced that their digital tools can offer an opportunity to address some of the challenges that women face in various low resource settings. However, I hope you also are leaving with how hard this work is, and that it's not as simple as just having a digital app that can do some type of nifty assessment or monitoring. And so I borrowed this section heading from a paper that I recently read, Digital Tools, eHealth or eChaos. And we just want to end with some of our thoughts about where this field is and where it's moving. So there's lots of digital innovation. However, in our exposure, there's very few effectively implemented at scale. And there's all kinds of challenges for this. For me, one of the most compelling is people are really inspired by and motivated by the technology, but very few people want to do the harder work, and I think as important, if not more important, work of thinking about how that technology really integrates into both a need that a person might face, but also the care pathway that already exists. And so the excitement on the development of the app, but failing to focus on integration, coordination, evaluation, adaptation, and regulation, the lack of funding to do those aspects of the work has really been a challenge for this. A lot of times we think about the apps in isolation of integration into existing care. So, Adeline is really thinking about what is happening on the wards and how this might both facilitate and also potentially disrupt. But oftentimes people are just saying, look, this wearable device can monitor women, so use it. Failing to get buy-in or trust either from the beneficiaries or from the clinical team. So just introducing technologies that no one wants to use because they don't believe that it's useful or they don't trust what's happening with it. And then finally, ongoing challenges with infrastructure and technical capacity. So really thinking about the resources that are available, not just to develop the app, but to sustain the app. What happens when they can't be recharged? What happens when there needs to be an update to the system? And so really thinking about the long-term sustainability of these needs to be considered just as much as we considered the development of algorithms or different apps to meet needs. Next slide, please. So this is something that Adeline shared with me a few days ago, but it's showing the complexity of taking a drug and getting it into the market and getting it really used and integrated into patient care. And we argue that the complexity of digital innovation is equal to this, that it's not just about having an app, it's about really thinking about this integration and getting it to market. And so this is a place where Adeline and I spend a lot of time thinking is not just about the apps that we think are promising, but thinking about how we get that into patient care and integrate it into existing systems. So with that, next slide and last slide, we recognize that really any health program, health intervention that's addressing a need needs to have this local relevance. So something that we do in Rwanda may not be off the shelf usable for Adeline's team in Uganda. And we need to make sure that we're thinking about addressing needs that are identified by health leaders and end users, that we're integrating into the local systems, that we're validating and evaluating and maintaining, thinking about that very much in the context where these are being deployed. However, we also think, and this is where Adeline and I have a lot of energy right now, that there's still learning to be had. And so some of that learning might be, my app will work in your setting. Let's think about how that can be integrated. And some of that can be taking particular aspects of a technology or taking some learning about failures in digital implementation and really taking that learning and facilitating implementation in multiple sites with that more global learning. And I like this quote here that talks about this balance, both of the local appropriateness of the digital innovation, but then also the opportunity to think big and think about how we can really inspire this work on a broader scale. So I believe that's it. Adeline and I are very grateful to be here. Looking forward to your feedback and ongoing discussion. I think we have some time for questions, and then we're always accessible if you want to reach out to us after the talk. So thank you, Adeline, and thank you to the team for the invitation.
Wow. Thank you, Adeline and Bethany. That was amazing. That was a really phenomenal talk. That's just amazing work you're doing. And I would also like to echo in the questions, multiple people have really said just extraordinary work. Implementation efforts for both studies were hugely impressive, wonderful presentations. I will take the first question from the question and answer. Do the community health workers get training before going out to monitor infections? This is for you, Bethany. And if so, what is the training?
So right now, in standard of care for community health workers in Rwanda, surgical site infection monitoring is not part of standard of care. So there currently is no training happening with community health workers broadly. Women who have cesarean deliveries, they're asked to go back to their health center every few days for wound dressing changes if that's needed, and then for general wound monitoring. In our own studies, we train study community health workers to go out as part of the delivery of the various interventions and evaluation of these interventions. And there's some basic monitoring, although again, a lot of our studies are to assess whether or not these other strategies can standardize the monitoring of surgical site infections. So we don't do a lot in diagnostics, but we do have a standardized training on just basic sanitation, and then if there are wound dressing changes that need to happen, to do that safely. There are a lot of conversations. I think it's a great question. There are a lot of conversations about what this would look like if it was actually deployed in terms of what community health workers can and should be doing in a home-based setting. But that is an ongoing conversation. So to be continued about what will happen if this is scaled up in practice.
Bethany, can I jump on with a question related to that? Have you considered at all looking at the app as a teaching tool? Because I wonder, after the community health workers have used it for a while, whether you can see that their performance independently predicting who has an infection or a complication might go up, because they're getting real-time feedback about, they probably have a suspicion.
Yeah, no, I think that's a great comment. And, really feeds into this. It's not necessarily a static intervention of, this algorithm, if it has high predictive ability, that's what we move forward with. I do think this idea of constantly evolving how we engage community health workers to facilitate that care and what they're learning through multiple assessments and their ability to function independent of the algorithm is a super important comment.
And I have a follow-on question to Joe for Bethany. And then we have a lot for Adeline as well. Bethany, you talked about the thermal camera. You talked about looking at the picture of the wound. Can you also incorporate vital signs into that?
We absolutely can. We don't currently have the data. So it's all about coupling data to the images to the surgical site infection diagnosis. So right now our images don't have enough standardized clinical information to build that into the algorithm. But when we implement the prospective study this fall, we'll be able to couple the image, the diagnoses with more clinical data. And we're working with folks like Adeline to really think about what that might be. And then touch wood, if we get this grant to scale this up to multiple countries, not only will we have a broader diversity in the types of women who we have images for, we can also have a bigger data set that includes clinical information to build into the algorithms.
Wonderful. We have some new questions that have popped up in the question and answer. And this one is for Adeline. Do we think the lack of impact on severe maternal outcomes was related to the study design? Would a pre and post intervention design be more likely to detect a difference than an interrupted time series? And then another question, wondering how you approach the stays for women in your work, and who are the decision makers on whether, actually, this is a great point for both of you. Who are the decision makers about the follow-up care? Or the follow-up after you detect something's wrong?
So to just address that first question, I think we're still doing a lot of thinking to understand the data that we have and the difference or lack of difference that we saw. I mean, I do think that the study design likely does play a role in not seeing a difference. I also think, as I mentioned, that we were very underpowered to detect a difference based on the rates that we were seeing. And one of the things that we are going to be looking at is even just the spillover. So, you know, if you start getting used to having vital signs, even if it's from a device, you might be more inclined to start collecting vital signs, even when you don't have the device. And so we did take a note of the documentation of vital signs through the whole study period. So that's something we can look over to understand that. And I think ultimately, you know, the study that we need to do is probably a large randomized clustered study where you just have the intervention on at certain facilities and not at other facilities. But I do, like I said, I think there is some work that we need to do before that to better understand who we should be using the monitoring and where. And I think that's where we want to go. So for the next step first, before getting to that larger study. And then in terms of thinking about the decision makers, and, you know, I'm sure Bethany has some thoughts on this. I will say certainly within the hospital, largely the women are, once they're there, what happens, I wouldn't say is independent of the decision makers, because oftentimes, even though they're public facilities where care is quote unquote free, there are a lot of stock outs and supplies. And so you need to buy and purchase things to facilitate their care. And often it's husbands or other family members who have those money-making decision-making. And also, interestingly, we did leverage this study to actually look at recovery after C-section. One aspect of that was asking women to respond to automated surveys on their phones. And so it was quite interesting because we often think of the penetrance of mobile phones as being very high, and it was, but a lot of the women would actually say, well, the phone belongs to my husband. So they have access to a phone, but it's not free liberal access. So they had to make sure that their husbands were okay with them staying in touch with the clinical team once they left the hospital. So I think the decision makers it's not just women. The women, there's certainly a lot of work to empower women and have them enable their own decisions. Bethany, I'm sure you have some thoughts there.
Yeah, a lot of overlapping thoughts with what you said. For Rwanda, one of the things we've observed in various studies is women who deliver via cesarean are asked to go back to the health facility, and the compliance for that is like 97%. And I think that's multifactorial for why it's so high, including individuals who are part of that decision-making process. If the woman doesn't have full agency by herself, that other individuals are compelled to do so. And similarly with the community health worker models, women are very accepting of community health workers coming in their home and supporting that care. And I think, again, that really speaks to how care is viewed and accepted, and protocols are explained just to communities. Two things that do come to mind for me. One is that, similar to Adeline, women didn't always have access to their own phones, and oftentimes it was through a partner or through a community health worker. So there's not just the agency, but it's also the accessibility. And so we actually had some follow-up arms that we called women. In our setting, that didn't work, because just expecting them to have a phone available to them for phone-based follow-up only, they were not always available. I think it was like 60% of women were available through that mechanism. So we've, for our settings, abandoned phone-based follow-up for that reason. The other thing that comes to mind is that study I was talking about, where we're looking at giving pamphlets to women or using flip books to educate women about monitoring their own recovery and what to look for in their own recovery. In qualitative studies, pretty universally, women ask that we educate not just them, but that we also provide that information to their partners and to the people who come to the hospital with them as caregivers, to get more of a community support around the things that they should be doing. So, one of the things we talk about is not doing heavy lifting. And so they ask that we make sure that everyone in their community knows that that's important for them during their recovery, not just the woman themselves. So I do think it speaks to it taking more than just the woman to be able to facilitate safe recovery.
Paul has a question in the question and answer. Those, I have to say, this is such a really interesting conversation, and it goes so far, I think, beyond the specific work you're doing, which is wonderful. But I think it's giving everyone ideas about their own work as well. How did the obstetrics and gynecology departments and nursing departments respond to remote monitoring? Were they supportive, or did they view it as an added hassle? So Adeline, I know you had those beautiful slides where you conveyed that. Could you also address this question as well?
Absolutely. And I think it's a very relevant question and important to think about. And I'll share with you a little bit of the backstory, which we often don't share. This wasn't a time here, but actually when we were putting together the study, our first thought was actually to have the residents in the department be the responding clinician, so to speak, in the lingo that we use here. We actually were not able to get IRB approval for that. They completely protected their residents. They felt that that would be a burden for the residents to have the responding, the phone, so to speak. I think that was, we struggled, and we went back and forth with the IRB quite a bit on this because, both local clinicians there and some of the residents felt like the residents actually are the ones who primarily take care of the women after a C-section, not necessarily after vaginal delivery, but certainly after C-section. So we actually thought it would be more important for the residents to be able to have access to this data. But after almost a year going back and forth with the IRB, we ended up pivoting and having the midwives be the responding clinician. And they were very accepting of it. And as you saw with some of the quotes, I think they really did find that it enhanced their care, because they often have to be in so many places at once. And there, at night, there's like a provider ratio of 1 to 50, for example. What we ended up, so we enrolled the midwives and then essentially the consultants. And so the consultants had access to the data. They didn't necessarily get the alerts, but they could see the vital signs. But what we did find is it also facilitated communication between the teams. So the nurses felt more empowered to talk to the residents because they had this data at their hands that they could tell them about. We found that some of the consultants were able to visualize the data and then call the midwife or call a resident to go and check the patient because they were seeing the vital signs. So I think there are some complexities with deploying this into the workflow and who gets the alerts. And, those of us who've been through clinical training and residency, nobody wants to carry the pager. And so there is always this thought about who has to be that responding clinician. And and that might vary in different settings. So certainly one of the aspects of implementation that we need to think about when deploying this type of technology.
I have one quick question that maybe I'll ask real quickly. So in terms of the outcomes that you're measuring, do you think there's some intermediate outcomes you might be able to measure that you definitely could impact? If the larger outcomes are quite complex and hard to address all at once, could you, for example, pick out particular care pathway things like time to, if you picked out the ones that had the biggest consequence and then look at like time to intervention or anything like that, could you look at intermediate markers that communication would be directly related to and make that an outcome?
Yeah, that's a really good thought, and certainly something I think we would like to do. One of the challenges is access to the documentation for those sort of processes. And so I think doing this on a K budget was a huge stretch. And so I think in a larger study where we can have a little bit more funding and to follow prospectively and maybe have a little bit more observation hours, that would certainly be something we'd want to look at.
Well,
I'd love to just, sorry, if I can just add one thought, because this is something Adeline and I were talking about the other day. Even if you don't show an increased benefit in a clinical outcome, if you show that it's equivalent care, but it's still preferred, it's still more affordable, it's still integrating within systems in a meaningful way, I don't think you rule it out because it's not significantly better, right? Like, I think there's still room for us to look at improvements in other domains of quality of care that are as important as just the clinical outcome itself. And I think this is a good case of that.
I have to say, I am thrilled to have gotten to hear you speak, and I know everyone else feels the same way. Amazing work. I have to say, that's probably the most impressive case study and results I've ever seen. It's like we just assumed you did like 2 R1s or something. So amazing presentation this morning. I know on behalf of everyone, we just want to really say thank you and keep up the phenomenal work.
Thank you so much for having us.
Thank you. Great to be here.